Mr. Jonathan Ramsay is a consultant urologist who has, over the past decade or so, uniquely focused on male infertility, from DNA fragmentation and testicular mapping right through to microbiomes. His talk is called Male Factor Infertility, the Limitations of Semen Analysis and the Role of Our Investigations. Thank you, Jonathan.
Good, well, thank you very much, Sangeeta. And I am really delighted to have this invitation because this is one of the few occasions in which I've been invited to speak to gynecologists and those interested in reproductive medicine. And I think it is an opportunity, really, for us to get together more and work towards having a more MDT approach to the whole subject. I was also interested in the last speaker and the definition of infertility as a disease as opposed to a condition. And whilst I think all of us might accept and the interesting geographical variations in the view of infertility, that this might be a disease of the female reproductive system, I think that rather broad definition leads us very nicely to the view that male factor infertility, 50% of the problem, may also be a disease of the male reproductive system. And if one takes the view that this is a disease, a condition, then that would lend itself very well to MDT working. So I make no excuse for some of the titles on these slides because some of them are derived from last year's talk to the general public at the Fertility show. But I think here is the message. We've mentioned the issue of the male factor being a medical condition in many cases, and just occasionally a serious medical condition, particularly when one is thinking of severe oligospermia, possibly a past history of undescended testis, and of course, therefore, the risk of testis cancer. But I think the starting points are these. Just like any other condition, male infertility, the dispossessed male partner, often feeling rather emasculated, I think it's important to acknowledge that this is a condition. And once one has acknowledged it's a condition, the rest, the investigation, the examination, and the treatment follows. And so here again, I'm plugging the role of an MDT, which would involve urologists and gynecologists, embryologists, and endocrinologists specialising in reproductive endocrinology. So where are we starting here? Well, of course, we're starting with a received wisdom that is, to put it mildly, nihilistic. The absence of any information about the importance of varicocele, Cochrane studies showing that supplements are of limited value. Certainly, those other features made negative, not positive, and actually running counter to what we know about disease in general. It would be very odd if the overweight man, certainly the obese man, did not have poor fertility, and indeed they do. And the consequence of that, of course, is that general health and attention to general health, I think, as we all know, may be quite important for male fertility. And then, of course, we know that we would check for headline infections, chlamydia, mycoplasma, but there really isn't any other mention of any other genital tract infection. And I think there is increasing evidence that the microbiome may well be relevant, just as relevant in the male genital tract as it may well be in the female. And then specific nihilistic views of DNA fragmentation. So the consequences of this nihilism is that we have created a situation in which we have decided that the intervention, which is IVF, is a treatment. And this is the treatment. And the consequence of that, of course, is that there is only one currency, that you don't move into any kind of treatment zone unless you are having IVF. And the funding, the currency, is exclusively for IVF, leaving really no funding for anything else. And I think that whilst this is nobody's fault, it is entirely understandable, because of course it is the right thing for a health maintenance organization, whether that be on a national governmental level or any other level, to provide the ability for childless couples to have children. But in fact, in so doing and putting all the money there, there is nothing left over to investigate the situation, and therefore there can be no progress. And of course, I would be the first, I am the first, to compliment and applaud what has happened in my professional lifetime with 25 or 30% of couples who would have been childless having children because of what was, of course, heralded as the miracle of IVF and ICSI. But of course, we would like IVF, the treatment, the solution, to work better. But if we look at the ESHRE statistics, then live birth rates, these are live birth rates, not clinical pregnancy rates, have scarcely shifted on the ESHRE 217 data. And I think that one of the reasons for this, again, it is a no-fault situation, is that if all the men are in fertility units, having treatment, having cycles, then of course they don't escape to the more general medical attendants and urologists in particular, so we don't learn anything about it. And we cannot literally practice as urologists in this field of fertility. And whilst I don't hold a candle for Jeremy Clarkson, he does come up with some very apposite remarks. And in this case, I think that the sperm is very much the reflection of the health of the man in many cases. And so where we are now, this is a fertility show slide, and I make no excuse for this, because we all know that the general public, particularly the infertile population, are gaining a lot of knowledge about this. And they perceive that the only way forward very often seems to be to have IVF or ICSI, and often repeatedly so. But of course, unlike any other medical treatment, almost any treatment, the result is binary. Happiness is a baby, a live birth, and unhappiness, the majority, is the consequence of it not succeeding. And therefore, we know that couples get into often a terrible situation where they perceive that this is just a numbers game, and they do all kinds of things to raise money to have more and more cycles, because the outcome is, as we all know, binary. So we're talking about confusing, I think, a solution with a treatment, and treatment involves the classic steps that we apply elsewhere in medicine. And I think the last of those, the care of the man who can feel increasingly emasculated as cycle after cycle fails, the care of that man is a very important thing. And it's a very difficult thing to do, because often the men become isolated and won't engage. And this gets worse and worse as the treatment proceeds. And actually, as we all know, some of these men do need support. Now this, the biopsychosocial model, has been applied to many diseases. And I think that the purpose of this Venn diagram is that if you don't get the bio right, then the social and psychological effects of that multiply. And these men often, their hard disk, their screensaver, is all about their low sperm count. And we've all seen these poor men who are absolutely obsessed with whether they have 1 or 2% normal forms on a semen analysis. And this is really a desperate situation for them. So again, a fertility unit slide. This goes back to the previous talk, really, but I was interested that, that in some of the socioeconomic factors, smoking was mentioned for sperm quality. Well, of course, there's an awful lot more to it than that. The Office of National Statistics reported that in the UK, 6% of all men were abusing steroids. That's a huge figure. And of course, it has an absolutely disastrous effect on spermatogenesis. Hair growth restorers, those who peddle these things, particularly the finasteride-based drugs, of course tell their patients that it won't have any effect, but anything that makes your hair grow and has quite a profound hormonal effect, particularly on dihydrocortisone, is absolutely bound to have effects on the prostate. And of course, it took David Attenborough to tell us that the sea was full of plastic. And we all said, oh yes, of course. But it's been full of plastic for a long time. And so have many of our foodstuffs. And we know about bisphenols, about other, both A and B, and about the plastics, which certainly in animal studies have a very profound endocrine disrupting effect in men. So these are a few questions that we can ask our patients. And this is not a difficult thing. And if our patients are in these categories, it is my experience that one can almost always improve their fertility, by which I don't just mean the semen analysis. It was very interesting that during lockdown, at the beginning of lockdown, when IVF treatments were suspended, and young couples who were waiting for a cycle of treatment, maybe their second or third, actually relaxed. They relaxed because there was nothing they could do to make it more likely that they would have a treatment cycle. They did concentrate upon their well-being, and there were quite a few pregnancies in people who, at least statistically, we might have thought were unlikely to achieve a natural conception. And so let's go back to NICE. The business about the varicocele really isn't true. There are few advantages of being as old as I and having trained before ICSI. So in the 80s, we used to repair men's varicoceles by open surgery whenever there was severe oligospermia, a large varicocele, and a small ipsilateral testis. And so before ICSI, actually, we knew that treating varicoceles was a good thing to do in a select group of patients. And there was old literature, this is 1980s literature, that showed as long as you selected your patients, you would get a good live birth rate after 6 or 8 months or so. And that's hardly surprising because, of course, the varicocele does heat the testis, the scrotum, quite significantly. And the same thing, of course, applies to the pelotons of cyclists we all see, particularly on the embankment in the summer, who are racing each other, all wearing lycra and getting very hot. So there's a lot of easy lifestyle stuff here. And we now know, just as we know that the varicocele alters DNA fragmentation, we know that infrequent ejaculation also causes a deterioration in sperm quality. And hence, the studies that show, they're very difficult studies to do nowadays, that show that if you elect, or if the couple elects not to have ART, then actually there is a significant cumulative pregnancy rate with low total motile sperm counts over a 2-year period. So we are not comparing in many of the couples whom we treat with IVF and ICSI, we are not comparing no chance of pregnancy with a reasonable chance. We're actually comparing low baselines, admittedly, but it isn't impossible that they should get pregnant. And one of the damaging psychological effects of going to a fertility unit is that, of course, not surprisingly, in order to justify such a big intervention, the patients will often say, are we going to achieve a pregnancy naturally? To which the universal response is no, because it's easier to say no. But actually, of course, the answer isn't no. And here is an interesting study that was done in 2015 with large numbers of patients. And they followed 1,100 patients. They looked at the definition of subfertility by WHO standards and then by the total motile sperm count. And when they looked at the total motile sperm count, you can see very significant numbers of ongoing pregnancies with what we would say, or many people would say, were impossibly low total motile sperm counts. And very interestingly, the so-called unexplained, of course, the so-called unexplained that may be suffering from a transient disorder actually achieved really quite significant spontaneous ongoing pregnancy rates. Now, before ICSI, again, it's an old man's prerogative to talk about this Canadian study from 1982. There was another one from Germany showing very similar things, that the cumulative pregnancy rate without intervention is not zero, really far from it. And one can use the total motile count as a guide. So this is not to say that I do not applaud or encourage IVF and ICSI. It is merely to say that the starting point is not a zero-sum game. So what do we need? This is what we need: a physical examination, ultrasound important, and hormone levels. Why? Well, for these two reasons, really. Number two is hotly disputed, but let's just have a look at DNA fragmentation and the explanation of unexplained infertility. So why would we dispute the validity of DNA fragmentation? It is because there are so many different ways of measuring it and so many different eponymous names. The sperm chromatin structural assay, the COMET, because on the right side, when you do a gel electrophoresis, the DNA spills out of the head of the sperm like a comet, and the sperm chromatin intensity measurements. And so each of these things is measuring a slightly different thing, and it is also expressed in a different way: an average fragmentation or a DNA fragmentation index. An index is quite different, of course, from an average, and therefore the numbers are not comparable, and they are not interchangeable. But it does help to explain, and it may help to improve ICSI outcomes. A big study from Australia, 2016, had some very significant results. Not a very well-controlled study, but nonetheless, this was giving us a view with 2,700 cycles that this DNA fragmentation business, SDF, may well have some currency. We did a smaller study, and I'm very pleased this is a bit like an MDT because they're gynecologists and urologists. This was actually from the Lister published last year, and did show that as one improved the DNA fragmentation, so the ICSI outcomes improved. And we can relate the DNA fragmentation to levels of oxidative stress, and we can actually measure these levels as reactive oxygen species, thus to more sensibly prescribe antioxidants. So these, I think, are the directions in which we should be going. We should be looking at DNA frag. We should be measuring oxidative stress. We should be mindful of lifestyle and nutrition, and we should also be mindful of testicular temperature, and I believe, subject of ongoing studies, the microbiome, not just in the vagina, not just in the uterus, but in the male genital tract. And so here we go. That's pretty simple, really. The wide range of germs. This was to the fertility show, but to us it's called a microbiome. And I genuinely believe that statement. And I think the second point here is really important, that giving the man some care, attention, and support really does a great deal for him, therefore for the relationship, and therefore possibly for the outcome. And this was where we started. Let's go for an MDT. I think that the notion which is springing up in fertility clinics that there's something about germs, so just give them all antibiotics. Please don't do that. Let's get together, talk about the cases, just as we would in other conditions, and make a plan. We might not be able to make this perfect. It's a really difficult subject, but just because we can't, I'm quite sure that we can do better. Thank you very much.
Thank you, Jonathan. That was very insightful and a very sensitive subject. People have posted a number of questions, and I know you can't stay for the panel afterwards. If I may just ask you a few now. You alluded to the way that men are portrayed in society and therefore psychologically traumatized by all of this. And you talked about MDT. And before we went live, you also talked about the fact that you're unique because you're a urologist, and most people anticipate having an andrologist involved. What do you think the ideal MDT would comprise in the infertility clinic, not just the gynecologist, for example?
Well, andrologist, the word is a tricky thing. It's a sort of basket of people. Because of course, a subspecialty of urology is andrology, including erectile dysfunction, ejaculatory disorders, testicular pain. But andrologist is also a term used for a biomedical scientist, as we know. And some embryologists will be styled, not unreasonably, as andrologists. So in this country, andrology has a dual meaning. And so there are urologists like I who will have a subspecialty interest in andrology, and they will deal with the other aspects of the male genital tract as well. So in the UK, there are probably about subspecialty trained urologists doing andrology. I wouldn't have thought there are more than 20. And of course, it's very difficult for these individuals within the health service to have a big infertility practice because all the men, by definition, are in infertility units where there aren't any urologists. And so the advice that they get maybe from embryologists, very good advice, but they don't get advice about their genital tract.
Thank you. There are a few other questions. We've got one from Amit Shah. It says, often I see andrology colleagues from the USA recommending TESE or alternative SSR procedures when they see high DNA fragmentation rather than ejaculated sperm ICSI. Is there any basis for that? And secondly, this person has also written, I still feel that evidence behind DNA frag assessment, interpretation, and its use in clinical practice is lacking. What are your thoughts?
Okay, so the second one first, it isn't. There's a lot of evidence about DNA fragmentation. The reason that it is confusing is because of the many eponymous types of tests. There are 5 different tests, ranging from those that are completely subjective. The halo test, which is subjective, it's visual under the microscope, and we know how tricky those tests can be, ranging from that to actually pretty sophisticated tests. They've all got eponyms: tunnel, comet, SCARSA. It's a minefield, and if you set out to really try and understand it, I confess, and I am sympathetic, you would think, I can't understand this. This is too much. It doesn't seem to relate to anything. But I assure you that if you stick to one test and get familiar with it, and you do it in all unexplained infertility, you will realize that this is relevant. Now, okay, so now let's go to the first question, which explains its relevance. Now, when you do a DNA fragmentation test, what any of them or all of them, you're looking at the total DNA damage in the DNA and the sperm. And in order to do that test, you break the two strands of the DNA. And DNA breaks in two ways. Either one strand breaks or both strands break. Now, the double strand breakage generally happens during spermatogenesis. And of course, if you separate the strands, you then can't tell whether the origin of the total DNA damage was double strand break, brackets in the testicle, or single strand break, which is occurring post-production in the genital tract for reasons of genital tract dysfunction or disease or inflammation or oxidative stress. Now, if you separate those two forms of damage, then this becomes an even more useful test. Because if you know that the DNA damage is single-stranded, that is happening post-spermatogenesis, then of course there is a clear rationale to do a testicular sperm retrieval synchronously at the same time as the vaginal egg collection to improve the DNA fragmentation of the sperm that you use, therefore to improve the outcome of the subsequent ICSI. But you have to be very careful. This is not a charter just to have a bit of a go and stuff a needle in another bloke's testicle, because the sperm in the testicle in a man with non-obstructive sperm in the ejaculate, therefore, may be a little immature, it may be a little immotile, and it doesn't freeze well. So you've got to be jolly careful that your embryologists are used to using testicular sperm, that you don't freeze it, and that you only do it when the damage to the DNA that you measure in the ejaculate is single rather than double-stranded. And we're developing some ways of being able to differentiate before you do a surgical sperm retrieval to improve DNA fragmentation, to differentiate those who will benefit from those who will not.
Thank you. That moves on to a question from Tanzila Gallo, which says, your thoughts on non-obstructive azoospermia and its treatment success rate? Oh, okay. Non-obstructive azoospermia, generally speaking, a bad condition. It slightly depends why you have the non-obstructive azoospermia and whether this was a primary or a secondary phenomenon, i.e. whether this is genetic or has a genetic basis, or whether it has happened as a result of a later insight, whether that be mumps, whether that be certain sorts of chemotherapy or other conditions. But generally speaking, the urologists, andrologists, we are guilty of talking this up and confusing sperm retrieval with the eventual outcome that we're all looking for, which is a live birth. So if you look at the live birth rates from all of those unfortunate men with non-obstructive azoospermia who have subsequently had some kind of sperm retrieval operation, then we are no greater than 20% and probably down at 14 or 15%. And that, of course, is because the sperm isn't very good. I believe that freezing that sperm does not help. So when there is an elective microtesia and the sperm that's retrieved is frozen, that might not be so successful. Very difficult to prove that, extremely difficult to prove it. But freezing poor quality DNA or DNA that starts off as poor quality and then thawing it is hardly likely to improve the outcome. So I think that sperm retrieval as an enterprise, as a treatment, not really a treatment, a solution, has to be entered into with great care so that we do not confuse the success of the sperm retrieval, which is up to 50% if you do a good microsurgical operation and you're experienced. We must not confuse that
as success with what we're really after, which is a live birth.
Yes, I agree with that. A quick question here from Mike Saris. Is there a place for Clomid in the treatment of oligoazospermia?
Okay, there probably is the answer. Once again, extremely difficult to prove. Extremely difficult to prove. And the responses, the hormonal responses to Clomid are various and unpredictable. But generally speaking, if you have an oligospermia and no element of obstruction, that's important, and an oligospermia with a relatively modest elevation of FSH, and particularly when testosterone is at the lower end of the range, then modifying both FSH and testosterone levels may well, this is experiential, very difficult to prove, may well improve spermatogenesis and might raise the sort of severe oligo or cryptospermia to a level where IVF with ICSI becomes a realistic option. So if there is a role for it, it is in that group of patients. But once again, you have to be careful. You do have to understand what you're doing. This is not an area where you can just have a bit of a go any more than I would have a bit of a go giving Clomid to women. I mean, the thought is appalling. But the trouble with us doctors is that once we've chucked a few drugs around in one direction, we sort of get a bit bold and start chucking them around in another. But be very careful. You can give a man much too much Clomid, his testosterone will go through the roof. The consequences of that is testosterone metabolism, his estradiol will go through the roof, so you'll have precisely the wrong effect. So be careful. There are also a group of men who suffer with Clomid, when you treat them with Clomid, from low libido despite a rising testosterone level. And you don't want to get yourself into that sort of mess. So back to the MDT, we want an input from reproductive endocrinologists who really love doing this. When I started working with one at Hammersmith, he used to give people, I suggested, give him a bit of tamoxifen, give him a bit of Clomid. And as an endocrinologist, he was seeing huge changes and measurable changes in FSH and testosterone. He thought it was Christmas. You know, for an endocrinologist, we've altered the hormone levels really radically in a month. You know, that doesn't happen. Yeah. So the answer is yes, I think so. But let's look at it together, and let's look at it together with our endocrinological colleagues.
Thank you. There's a short question here which says, what is considered the normal range for a sperm count? And I have heard patients in the past being advised you only need one sperm.
Sure. Well, you only need one sperm. I'm sort of quite enthusiastic. I don't quite put it like that, but at least if you say that, they don't stop having sex altogether. And of course, there are lots of reasons for having sex, only one of which is fertility. The other one is to keep them together and try so that they can try and comfort each other. And if you tell them there's absolutely no chance of anything, then that might not be the best thing to do. So whilst I don't support, of course not, being economical with the truth, then I think we have to be very careful in our advice, because there can be very long-term consequences of a lot of casual remarks in this subject. So the answer to your question is, I look at the total motile sperm count. I think that is a better marker of the likelihood of conception than is sperm morphology, for example. Unless, of course, when sperm morphology is persistently zero, it's a subjective measurement, but when it's persistently zero, then I think it's relevant. So let's look at the total motile sperm count, that is the percentage progressively motile sperm as a percentage of the total sperm in the ejaculate. And when that is above 20, then that is their chances of a natural conception are probably not that far removed, depending upon female age, from one cycle of IVF.
Thank you. Can men improve their genital tract microbiome And how should they do this?
Okay, fascinating question. I think the answer is probably yes. So there are a lot of organisms that we thought were irrelevant to everything. Some of them anaerobes they've all got funny names. Prevotella, atobium, but they are anaerobic. And it is very interesting that where we've got to at the moment with this is that if you do next generation microarray sequencing on all the organisms in a specimen of seminal fluid, then we know that the fertile specimens, those of seminal fluid from men who've had children, have a higher level of lactobacilli of various strains than those who are infertile. So here is more than a coincidence between the male genital tract and the female for health. So I think this is a clue to the importance of the microbiome. Now, I know nothing, but what I think, and again, being very old, I'm allowed to think, I think it is relevant, but I also think and know that we mess with this at our peril. Because of course, you might treat a headline organism, an enterococcus, with a broad spectrum antibiotic. Now you might get rid of that, and my experience, sometimes when you do, particularly the Enterococcus faecalis, there is an improvement. But it's a bit like Clomid. You might also mess with the microbiome and make it a lot worse. So our understanding is at best rudimentary at the moment, but I think this direction represents the future and possibly great avenues for treatment in the future. But I'm not going to recommend anything because I know you all go off and start doing it, and that might make them worse.
Thank you. Which DNA fragmentation test do you prefer? Valerie Salt asked that question.
Yeah, well, who asked?
Valerie Salt.
Hi. So, yeah, that's a very good question. So, of the ones available in the UK, we have Halo that anybody can do because it's a kit and it's visual down the microscope, and you just look at the halo of stained DNA that comes out of the sperm head. I wouldn't recommend that, except, of course, if you have an operative who has done hundreds or thousands of these, then the visual appreciation, the subjective appreciation of the simple halo can be very useful. And when people have compared the halo with other tests, more sophisticated, if you've got a very good operative, but it's a craft specialty, then the results are valid. The other two are the COMET, which is a gel electrophoresis test, the COMET test, and the SCSA, the sperm chromatin structural assay. Now that gives an index. The SCSA gives an index, and it is measured by flow cytometry, 6,000 sperm, stained, DNA broken up through a flow cytometer. Now, the protagonists of the SCSA say, this is the only test you can do, it's 6,000 sperm, you can't do it on fewer sperm than that, and it's a flow cytometer, which is a jolly nice machine, and of course machines don't lie, so it's got to be the best test. I'm not so sure that that's true. Flow cytometers get gummed up with the dye that is used to break up the DNA, and it's actually quite a difficult test to calibrate and get right. However, the results are very, very consistent when done by a big company that does thousands. But it is giving an index, and the results don't relate quite so well to IVF outcomes. What it does do is that when it is plumb normal, really normal, then in my opinion, that bloke's fertile. The COMET test, the single cell gel electrophoresis, looks at 100 sperm and image analyzes that COMET. And it gives attractive data because it divides the sperm with an average into poor quality, intermediate quality, and good quality. So it's very user-friendly. The trouble with it is that it is the reverse of the SCSA, because the normal fertile controls could only be measured in the context of a fertility unit, and these were highly fertile young men who were almost professional sperm donors. So the trouble with the COMET is that the threshold for normality is set a bit high, but actually the categories, once you get into the laboratory, are, I believe, quite useful for predicting ICSI IVF success, and indeed deciding, in the presence of unexplained infertility where there is normospermia, whether actually this couple would do better with ICSI, whereas you would have chosen, looking at his semen analysis, IVF. So different tests for different purposes. I have equal knowledge of the SCSA and the COMET, and I do use each in different circumstances. But if you were going to choose one, I think I would probably, in the UK, go for single cell gel electrophoresis. In the world, I would probably go for tunnel.
Thank you. And finally, when this fails, what is there left for these men who obviously in a very vulnerable situation? DNA fragmentation fails and all the modifications.
So when they have failed despite...
It says, sorry, if after doing all lifestyle changes, DNA fragmentation is poor, what do we have to offer these men? Okay,
so all the lifestyle changes, yes. Measuring their oxidative stress levels and making sure that they are taking neither too much antioxidant or too little. It's easy to overdose on antioxidants. So really you can only get a feel for this if you actually measure what it is you're treating. So yes, the antioxidants. I interrogate the situation with microorganisms very thoroughly, and I make sure I've treated those. Make sure you treated the varicocele. Now, generally speaking, if the man's efforts, aided by his wife, who's usually the management here, and all the urologist's efforts do not improve the fragmentation, then this will be double strand break, which is coming from the testicle, and it will not be amenable to treatment. But it is important, I think, to understand that, because once one does understand that, in these poor men and women who've gone through 3 cycles and few blastocysts or loads of miscarriages, then once you know that this is a problem with spermatogenesis, and this is set, this is the way it's always been, then at least you can explain it. Because one of the disasters in the situation just described is that often it remains unexplained. And when it's unexplained, we know what happens. They're very unhappy, they're very miserable. Sometimes the relationship breaks up. They've mortgaged their house 3 times already. Their mothers and fathers have run out of money, and they're still pushing on because they haven't got the answer. And I think we owe it to these men, these couples, and their parents, crikey, to try to explain, at least at worst, to draw a halt to this. I think I've lost you, Sangeeta.
My apologies. I was just thanking you for a riveting Q&A discussion after a very enlightening and sensitive discussion of male factor infertility. Thank you. And it's a shame we can't have you for the panel discussion, but thank you again.
Well, I've got to drive home, you see. It's miles away.
Thank you again.
Good. Lovely. Thank you very much. Thank you, everybody.